Evening, EDIC Part 1 aspirants and our honorable faculty. Our today's domain is about infectious and immune disorder, which would be conducted by Dr. Brajendra Lakhar. Sir, he's a director of critical care in medicine at Health City Hospital, Guwahati, Assam. His area of interest are as follows: critical care in resource poor situation, sepsis, and MOF. Over to you, sir.
Good evening, everybody. So, my assigned topic is actually infections and immune disorders, and it's a huge topic. Rather, it will be a discussion point, and the whole discussion point will be from anaphylaxis, host defense and immunity deficiency, HIV and AIDS, sepsis and septic shock, nosocomial infections, how you use antibiotic in ICU or in hospital. This I'll cover. There's so many others, like you have a tropical infection and you have fungal infection, which probably will be beyond the scope of the time frame probably. So how I'll try to touch upon important points here for each topic, and then we can discuss. If you have anything to ask in between, we can always discuss in between. Okay. So let us start with anaphylaxis. So what is anaphylaxis? It is an acute, potentially lethal, multi-system syndrome. It is resulting from the sudden release of mast cell and basophil-derived mediators into the circulation. So it has to be few points. It is acute, and it's potentially lethal. If you don't treat, probably it may lead to death. It involves multi-system, and it's related to mast cell and basophil-derived mediators. The mast cell and basophil, they release a lot of cytokines or mediators to have the multi-organ involvement. So it's 10 to 20 per 100,000 population, and the incidence is increasing very high because of the probably varieties of food habits and the drugs and so much allergens we have surrounding us. But as a whole in ICU, the incidence is not very high. It's less than 0.3% in adult admission in ICU because of anaphylaxis. Many of the anaphylaxis may not be evident, or many of the anaphylaxis may be missed. Like, as for example, if someone is on ventilator, on sedated and paralyzed, and he develops some sort of anaphylaxis to one component of one molecule, it is very difficult to detect on that situation. But as such, there is the incidence due to anaphylaxis is less than 0.3% in adult and 0.1% in childhood. The largest number of incidences of anaphylaxis is in children, basically. But a good point is that almost more than 90% of them are expected to survive. So risk factor of severity is usually the food allergy in teenagers and elderly. Someone is having bronchial asthma, they are already having bronchial hyperactivity. Someone is having cardiac disease, coronary artery disease, they have got less reserve, cardiac reserve, causing more damage. If someone is hypertension and with some beta blockers or AC inhibitors, they are at risk of having bad prognosis. And so there are some mast cell activity disorders. They are inherently prone to have this kind of problem. So there are causes like food. We have almost these 5 food: peanuts, fish, and crustacea. They constitute almost 90% of the food allergy. And egg, milk, wheat, soy. So the whole thing, food constitutes most of the cases. And fish is very, very common. Fish allergy is very, very common. If you take drugs, cephalosporin and penicillin groups are common. We know the sulfur drugs, then vancomycin, sulfonamides, then aspirins, non-steroidal anti-inflammatory drugs, contrast media. We come across many cases. Someone who is in AC inhibitor, ARVs, they are also the may cause of allergy. Then there are colloids, then meat also may cause, and gelatin-based colloids, they are the causes. Blood products, after blood transfusion, many may have anaphylaxis, and latex as a particle. There are some anaphylactic toxins like complement 3A, complement 4A, complement 5A. They are taken as anaphylactosis. And as I said, there are some mast cell disorders inherently they are prone to have more anaphylaxis, like mutation of tyrosine kinase receptor. Then there are monoclonal mast cell activation syndrome, and there's a non-clonal mast cell activation syndrome. So they are inherently, even in stress also, if someone is doing exercise, they may trigger that mast cell to degranulate, release this kind of mast cell degranulation, causing release of huge amount of histamines and cytokines to the system, causing anaphylaxis. So if you take paralysis here, this is a busy diagram, but still I'd like to simplify it. Food, insects, things bite, they may cause immunogenic, IgE dependent. If you take drugs can cause both immunogenic and immunologic or non-immunologic. But in immunologic, there are IgE dependent and there is IgE independent. So the drugs may cause immunologic, IgE dependent, IgE independent, or non-immunologic, like physical stimuli. These drugs can cause. Exercise, environment, heat, sun exposure, they can cause non-immunologic physical stimuli. And this may, IgE dependent may actually, the initial exposure to antigen, this antigen presenting cells present antigen to T helper cells, and T helper cells stimulates B cells to differentiate into plasma cell and produce IgE against antigen. And this may happen in someone who is genetically predisposed. This may happen directly. And IgE binds to some receptors in the mast cell and sensitizing to that antigen. And on the second exposure or re-exposure, this antigen causes cross-linkage of the IgE and the receptor FcRI on mast cell, causing inappropriate mast cell activation. Similarly, the other immunologic, which is IgE independent, the generation of anaphylaxis like complement pathways, complement 3A, 4A, 5A, and they cause inappropriate activation of mast cell activation. And physical stimuli like in extreme exposure to heat, cold, sunlight, environment, or heavy exercise in a prone patient may have non-immunologic physical stimuli cause inappropriate mast cell activation, causing immediate phase, which occurs within seconds to minutes, mast cell degranulation, releasing histamine, lipid mediators like prostaglandins, leukotrienes, other mediators like platelet activating factor, tryptase, tumor necrosis factors. They all cause inflammatory mediators, cause vasodilation, vascular permeability, smooth muscle contraction in airway, mucus secretion, recruitment of the inflammatory cells, and autonomic nervous system stimulation, activation. So this actually leads to a life-threatening sedation. So this is the way actually this happens, and there are three pathways, and we should know this: immunologic, IgE dependent, immunologic, IgE independent, and some non-immunologic physical pathway. To make it more simple, or allergen may be IgE dependent, or directly they may stimulate mast cell degranulation. These histamine and some chemical substances are released, which goes to the blood circulation, causing whole system affection, causing affecting the CNS system, heart, vasodilation. There is one syndrome like Coney syndrome, which is ST elevation in an anaphylaxis, and this is called Coney syndrome. And kidneys may be affected, intestine, GI system, lungs, airways. So what are the signs of symptoms? So if we say how to diagnose anaphylaxis, any one of the following, if acute onset of skin and mucous involvement with more than one, like if respiratory compromise or hypotension occurs, along with skin and mucosal involvement, we can call it any one of these. If repeat onset of symptoms after exposure to a likely allergen and more than either skin and mucosal involvement, respiratory symptoms, hypotension or persistent GI symptoms, then also it can be an anaphylaxis. And hypotension after exposure to a known allergen. Suppose someone is allergic to, suspected allergic to sulfonamides, and he was accidentally exposed to sulfur drug again, and presenting to us as hypotension, we'll call it as anaphylaxis, even without having all the skin and others. So there is some grading of anaphylaxis, like a long time back in 1997, Ring and Messner's, they graded it like grade 1, 2, 3, 4. And where the skin is involved, like local pruritus, flushing, urticaria, angina, they will label it as grade 1. If along with GI symptoms, mild nausea, cramping, starts, or if a respiratory system like rhinorrhea or hoarseness of voice comes up, or there may be tachycardia, this is 120, more than 120, blood pressure changes, drop more than 20 millimeter of mercury, or arrhythmia. If any one of this is present, then probably will stage is 2, second stage or third stage is same, but it will be, if someone is on shock, it will be a third stage. Someone had cardiac arrest, will be a stage 4. And similarly, in 2004, they tried to modify it and make it more simpler by putting it mild, where skin and subcutaneous tissue only affected. They call it mild. If it's a such thing, respiratory, cardiovascular, GI symptom involved, and then it is moderate, where the symptoms are not that very severe, like they have dyspnea, stridor, wheeze, nausea are there. But severe is hypoxia, hypertension, or neurological compromise. Then that is called severe. This grading is also important there, because the intervention and may also vary. The which this also vary according to the grade. So if you come to the treatment part, the priority of initial management is early adrenaline. We must start adrenaline as early as possible. That comes first. Rapid administration of IV fluid to correct hypovolemia. We know that the third spacing is very high. The fluid goes into the third space very high amount, and that's why the almost 30% of the volume may lost into the third space, and that's why we need to give a lot of IV fluid. There is aggressive management of threatened or established respiratory failure. If someone is having respiratory failure, we'll have to treat it very, very aggressively. And interestingly, the supine position is extremely important. There are earlier studies so that in a landmark observation, they said 10 died out of 37. They did a review of those death cases. They've seen that they were taken into an erect posture, causing sudden collapse. In fact, their ventricles were empty. So there's sudden drop in blood pressure causing cardiac arrest. So it's extremely important, even in mild or moderate cases also, we must keep the patient in supine. Any patient is in shock, legs should be elevated. And oxygen supplementation, as you know, should be given. IV access is large vein, arterial lines if presence of cardiovascular collapse. So you'll have to do according to any seriously shock patient. Aero breathing is again unless we give something to reverse the pathological process, which can be reversed by adrenaline only. And it is difficult to, if we delay it, then it will be difficult. The early intubation, because later on intubation may be extremely difficult, and be prepared for difficult intubation because of spasm and a lot of edema around the airways. Severe bronchospasm should be managed according to the guideline of, just like managing a severe asthma, we'll have to give a lot of nebulization, bronchodilators, and even ventilator managements also are according to the severe asthma guideline. So in circulation, adrenaline is the drug of choice. We give 500 micrograms IM every 5 minutes, and we can give very extreme situation where severe hypertension, we may give IV bolus 50 to 100 micrograms. If someone is non-responders, we can give norepinephrine infusion. We can add vasopressin later on. In extreme vasoplexy shock, we may go up to methylene blue or glucagon addition. And IV fluid, we should give 220 ml per kg body weight as crystalline, but we can go up to 50 ml per kg body weight. But once we give this additional amount of fluid, and if we have already given more than 4 shots of adrenaline, 500 micrograms, then probably next subsequent fluid management must be guided by hemodynamic parameters. We must have echocardiographic or some sort of hemodynamic parameters which should guide our fluid therapy. Many situations, the patients may need a lot more fluid than actually expected. And their ECMO may be tried in extreme situation where resuscitated anaphylactic shock patient. If significant pump failure persists, probably ECMO, where it is available, we can consider. There's supplemental management like antihistaminic combination of H2 or H2 antagonists like diphenhydramine and H2 antagonists like ranitidine. They will block all the antihistaminics. Corticosteroids to prevent prolonged and biphasic reaction. Corticosteroid doesn't help in immediate action, but they help in 2 ways. It prevents the biphasic reaction, late reaction, and also in bronchospasm they help. So the dose is 1 to 2 milligram per kg body weight. And glucagon will be considered if a patient is on beta blocker, they develop anaphylaxis or anaphylactic shock. Glucagon is a rescue therapy. Non-arterial angioedema is one area we should be aware of. There are acquired complement 1 C1 esterase inhibitor deficiency, and someone patient is on AC inhibitors, they may have non-arterial angioedema. They may not have any itching, but they may have edema surrounding facial, orofacial, or in the body. And the first line of treatment, like adrenaline and antihistaminics and steroids, they may not be effective. They may be ineffective. And interestingly, tranexamic acid is the drugs to be used, and they are useful. So these conditions we always should remember, because someone who is antihypertensive like AC inhibitors, and we should suspect, and someone is giving history of repeated angioedema without having itching. This may be one situation we miss many a time. Further, we should remove the trigger. Any trigger we should identify, and we should be very specific that this should not happen again. And observation after anaphylaxis is also very important. If mild anaphylaxis, we must observe the patient for 6 hours. And if someone is in shock, patient should be admitted. Patient needing support, respiratory support again in ICU. And most of the cases, they are reversed within 12 hours. In fact, even ventilated patient also, if we treat very correctly or aggressively, by 12 hours to 24 hours, they are actually out of ICU. And follow-up management again. So we must identify and give an advice to the patient that these are the trigger agent, and this should be avoided. The drugs or food or article which actually trigger the anaphylaxis, they should be avoided. So that was just the nutshell about anaphylaxis. We can discuss again. Next, we'll come to host defense and immune deficiency. Anyone want to have any discussion on or any comment on this, or any question on anaphylaxis? You can always note down, or we can discuss in the after finishing the discussion part. Okay. So next we come to host defense and immunodeficiency. Again, I'd like to outline the host defense and immunodeficiency. It's not an exhaustive discussion, but I'd like to touch upon very basic points where immunity is concerned. Diverse host defense mechanism protect human body from variety of microorganisms and cancer. We have a natural defense mechanism, which we call innate immunity, which provides immediate but non-specific response to infection. Any infection, be it virus, bacteria, or fungi, or a cancer cell even, the innate immunity will try to protect our body from those insults. And adaptive immunity response is delayed and relies on antigen presentation to lymphocytes. Again, the body will respond to some antigens, and they will process the antigen, and the body will try to adapt so that the next time that infection, that agent comes to our body, they will try to kill that down and protect our body. The adaptive immunity actually exhibit is very specific. Memory, actually, they memorize they remember the bugs, so that the next time the bugs come, they will be more aggressive to kill that bug. Amplification, they amplify every time the infection comes. The response to that will be amplified. And diversity, I'll come to that again. So if we see cell types, that the types of innate immunity, the mast cell, then nasal killer cell, then dendritic cell, macrophages, complement protein. Okay, this again, necessarily the germs and bugs are killed by nasal killer cell by phagocytosis. They engulf the bugs so that they kill the germs. And the complement protein, actually, they opsonize. Actually, they identify which foreign body to be killed. They will try to protect the body by identifying and opsonizing. They will attach to that one to identify by the nasal killer cells to be killed later on. Basophil, eosinophil, and neutrophil, they are all again in a tissue phase, they convert into killer cells, and so that they phagocytose most of the bugs in the tissues. So again, in the cellular immunity, the T helper cell and nasal killer cell will be again part of the cellular immunity. I'll come to that. The T cell can be sent to CD4 and CD8 type, and a humoral cell actually B cell type, where they produce antibody. So if you come here, damage-associated pattern and PMPs, they call pathogen-associated molecular pattern. And damage-associated molecular patterns, like in stress and damaged tissues, they release some molecules or proteins. And in pathogen like bacteria and virus, they release some pathogen-associated molecular patterns. And these patterns these proteins are actually engulfed by dendritic cells, and these dendritic cells will kill that and process that protein. And whether the virus, they will follow this. If it is bacteria, they will follow. In bacteria, interleukin-12 is affected. The nasal killer cell will try to release interferon, gamma interferon, and the neutrophil and CD4/64 will be high, and ultimately they will protect the body by engulfing the bugs. In the viral side, interferon alpha and beta in the monocyte will be stimulated. CD4, CD169 will be high, and the virus will be killed. And some in dendritic cell again, they measure MHC2 type, and interferon alpha and beta, they release T cell will be stimulated, because the antigen from the dendritic cell, they will be called again antigen presenting cell. And then T cell will be again releasing a lot of T helper cell, specific T cells, which will help our immunity. And B cell will release antibodies to that specific bacteria for future. So this is the very basic and simplified way to look into innate and adaptive immunity in our body.